The debate was a lot of fun. It is a controversial area, and basically we talked about two arenas. To my mind, the studies looked at a particular population for use of genomic tests in order to omit chemotherapy. That was the topic that we talked about. Very high-risk patients, very young patients, for example, under 40, patients with multiple involved nodes, patients with locally advanced cancers were really not studied in the seminal trials. And so to my mind, and my argument was that there really isn't a good use of genomic tests in that setting. We also talked about the premenopausal node positive data. We now have 3 trials that all found no advantage to chemotherapy in postmenopausal women who have moderately high clinical risk and low genomic test results. But in the premenopausal patients, there didn't appear to be much of a usefulness of the tests. And so we had an active discussion about ways to manage that and the reasons for it, which might relate to ovarian function suppression, but that doesn't seem to fully explain it. Or it may relate to the biology of the cancer. And Dr. Harbeck was the other debater. And the WSG group has done several trials where they tried to add to genomic understanding through doing brief exposure to endocrine therapy and an in vivo endocrine sensitivity testing with Ki-67 as a marker. And she talked a lot about the potential for that to be a way forward.